Hello, everyone. I'm Rob Sargis, an endocrinologist at the University of Illinois at Chicago, and I'm excited to speak to you today about the links between environmental endocrine disrupting chemicals and metabolic diseases. Our goals today are to appreciate the global burden of metabolic disease, understand the evidence linking endocrine disruptors with metabolic disorders, recognize the role of environmental injustice in metabolic disease disparities, and to learn how to take action to address environmental drivers of metabolic disease risk in our patients. As you may be aware, metabolic disorders like obesity, diabetes, and non-alcoholic fatty liver disease are now rampant across society. It's currently estimated that nearly 40% of American adults are obese. But perhaps even more concerning is that over 18% of children and adolescents are as well. This rise in obesity has led to a rapid increase in non-alcoholic fatty liver disease and is an important risk factor for diabetes, which now afflicts over 30 million Americans. Importantly, this diabetes pandemic is not restricted to the US. It's currently estimated that 425 million people globally now have diabetes, with a projected 629 million to have the disease by 2045. The consequences of diabetes are grave. It's the leading cause of adult blindness, kidney failure, and non-traumatic amputations. It's also a potent driver of cardiovascular disease, which kills approximately 2/3 of those with diabetes. In addition to the individual morbidity and mortality of diabetes, it places a tremendous toll on society. Diabetes costs the US economy $327 billion per year, a rapidly increasing number that doesn't take into account the over 7 million people in the US who have undiagnosed disease. To address this public health crisis requires us to identify and address all factors that promote the development of metabolic dysfunction. To be clear, it is beyond doubt that excess energy intake and physical inactivity promote the development of obesity, diabetes, and non-alcoholic fatty liver disease. It is also clear that genetic susceptibility plays an important role in this process. These relationships are unequivocal. It is also becoming clear that emerging risk factors like sleep disturbances likely play a role. But these factors alone fail to fully account for the magnitude and rapidity with which metabolic disease rates have exploded across the globe. As such, attention is turned to the contribution of other factors, including endocrine disruptors. This graph shows the dramatic rise in both US diabetes rates in red and US synthetic chemical production in blue over the last 70 plus years. To be clear, the fact that these curves are superimposable does not mean that these phenomena are necessarily causally linked. Rather, I am simply using this slide to illustrate the dramatic rise in our use and dissemination of synthetic chemicals over the time frame in which diabetes rates have risen rapidly, in order to illustrate an important change in our societal habits that often goes unappreciated. But there is indeed robust causal evidence that environmental toxicants are linked to obesity, fatty liver, and diabetes. These chemicals include those used in agriculture, in our homes, and for our self-care. They also include chemicals arising from industrial activity and medical care. We are, in fact, exposed to chemicals that disrupt metabolism in nearly all realms of our life. To illustrate the robustness of the data, let's consider the pathogenesis of type 2 diabetes. In normal physiology, insulin secretion and insulin action are tightly matched to ensure the adequate but economic delivery of glucose to peripheral tissues, which is shown in green. If one loses weight and exercises, they slide down the curve from point A to B. Insulin sensitivity improves, and insulin secretion is reduced to maintain euglycemia. The problem is that most of society is moving in the opposite direction. If one gains weight, becomes less active, is unable to get good sleep, they slide up the curve from point A to C. Insulin sensitivity declines, and insulin secretion must pick up to maintain euglycemia. Unfortunately, this demand for more insulin secretion stresses pancreatic beta cells, and they begin to fail. Initially, during periods of peak insulin demand, which results in impaired glucose tolerance, point D, shown in yellow, which then progresses to frank type 2 diabetes, point E, shown in red. Over the last 15 years, a robust and diverse array of studies have been conducted to examine how environmental toxicants disrupt glucose control. These include cell and tissue-based assays, animal studies, epidemiological work, and even clinical studies. Indeed, a diverse array of environmental toxicants have been shown to impair insulin action, insulin secretion, or both. And importantly, these are not simply associations. Rather, strong studies have ascribed precise molecular mechanisms by which endocrine disrupting chemicals disrupt metabolic homeostasis. The data are strong. Moreover, there is now evidence that these chemicals not only promote disease development, but likely increase the risk of developing the micro and macrovascular complications of diabetes. Importantly, given the fact that each of us is exposed to hundreds, if not thousands of chemicals, it is not hard to imagine how an individual's cocktail of exposures that alter metabolic regulation could interact with their diet, activity, and genetics to increase their risk of developing obesity, fatty liver disease, and diabetes. Endocrine disruptors are an important component of the larger environmental ecosystem. Interestingly, it is becoming increasingly clear that our ecosystem influences development. And indeed, an expanding body of scientific data now indicate that exposures to endocrine disruptors that occur during sensitive periods of development, particularly early in life, can promote the long-term risk of metabolic disease in individuals and potentially across generations. Amplifying the tragedy of the metabolic disease epidemic is the disproportionate burden it places on vulnerable communities. We have known for a long time that specific racial and ethnic groups have higher rates of diabetes. What is particularly disheartening, however, is the fact that despite this knowledge, there is evidence that these health disparities are increasing. Importantly, it is not just the higher prevalence of diabetes among racial and ethnic minorities, as well as those with low incomes, that is the issue. It is also deeply tragic that the consequences of diabetes are greater among these groups, including diabetes-related mortality. A number of different factors have been proposed to explain these egregious health disparities. What is less appreciated, however, is the contribution of environmental injustice to the higher burden of diabetes and its consequences in these vulnerable communities. In an analysis of 5 classes of endocrine disrupting chemicals linked to diabetes by both robust basic science evidence and prospective epidemiologic studies, data indicate that exposure to all 5 is higher among racial and ethnic minorities, as well as those with low incomes. These include legacy chemicals, such as polychlorinated biphenyls and organochlorine pesticides, as well as chemicals to which people are continuously exposed, including bisphenol A, phthalates, and various chemical constituents of air pollution. In addition to the higher levels of exposure in these communities, there's also evidence that the impact of these exposures may be more detrimental among these groups. Eliminating health disparities mandates that we address its environmental drivers. The good news in all of this is that unlike genetics, environmental exposures are modifiable. We can reduce exposure to these risk factors in order to help address the current metabolic disease pandemic. To do so will require action on multiple fronts. As discussed in a previous presentation, we need to empower our patients as well as the public with knowledge on how they can reduce their exposures. We must educate our students, residents, fellows, and colleagues on the importance of the environment in driving disease risk. We need to encourage our professional organizations to acknowledge the contribution of the environment to disease risk and to advocate for measures to address that risk through changes in clinical practice and public policy. And as physicians, we need to use our voices to advocate for science-based public policy that screens chemicals for their metabolism disrupting properties, prioritizes human health, and in the end, eliminates the use of chemicals that increase morbidity and mortality, as well as the disproportionate burden of disease in vulnerable communities. All of this most certainly can be done. In closing, I hope you have gotten a sense of the tremendous global burden of metabolic disorders like obesity and diabetes, as well as the disproportionate toll they take in vulnerable communities. I hope you've gotten a flavor of the evidence linking endocrine disruptors to metabolic dysfunction and how disproportionate exposure to those chemicals likely contribute to metabolic disease disparities. And in the end, I hope you feel the need for action to reduce exposure to metabolism disrupting chemicals in our patients and across society at large. Thank you for taking the time to watch this video. As more of us become aware of the links between environmental exposures and metabolic disease risk, the more likely we are to take action to improve human health.